Welcome to Empowering Nurses to Protect Themselves and Their Patients, Nurses' Role in Antibiotic Stewardship. The audio for today's conference will be coming through your computer speakers. Please ensure your speakers are turned on and the volume up. The next 4 slides will cover the continuing education information for today's webinar. CME. The Centers for Disease Control and Prevention is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Centers for Disease Control and Prevention designates this live activity for a maximum of 1 AMA PRA Category 1 credits. Physicians should claim only that credit commensurate with the extent of their participation in the activity. CNE. The Centers for Disease Control and Prevention is accredited as a provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. This activity provides 1 contact hour. CEU. The Centers for Disease Control and Prevention is authorized by IACET to offer 0.1 CEUs for this program. CECH. Sponsored by the Centers for Disease Control and Prevention, a designated provider of continuing education contact hours, CECH, in health education by the National Commission for Health Education Credentialing Incorporated. This program is designated for certified health education specialists and or master certified health education specialists to receive up to 1 total Category 1 continuing education contact hours. CDC provider number is 98614. CPE. The Centers for Disease Control and Prevention is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This program is a designated event for pharmacists to receive 0.1 CEUs in pharmacy education. The universal activity number is 0387-000-18-097-L05-P. This activity has been designated as knowledge-based. Once credit is claimed, an unofficial statement of credit is immediately available on TCE Online. Official credit will be uploaded within 60 days on the NABP CPE monitor. For certified public health professionals, the Centers for Disease Control and Prevention is a pre-approved provider of certified in public health recertification credits and is authorized to offer 1 CPH recertification credits for this program. CDC is an approved provider of CPH recertification credits by the National Board of Public Health Examiners. Effective October 1, 2013, the National Board of Public Health Examiners accepts continuing education units for CPH recertification credits from CDC. Please select CEU as your choice of continuing education when registering for a course on TCE Online. Learners seeking CPH should use the guidelines provided by the NBPHE for calculating recertification credits. Please visit their website for assistance. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, our presenters, and their spouses or partners wish to disclose they have no financial interest or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. The The CDC estimates that at least 2 million people are infected with antibiotic-resistant bacteria, and at least 23,000 people die each year as a result of those infections. As the most trusted profession that spends the most time with patients, the nurse's presence and leadership in developing antibiotic stewardship programs is essential. This webinar will use the ANA and CDC white paper as a framework to describe the problem of antibiotics resistance, embrace the nurse's expanded role in hospital antibiotic stewardship programs, and describe key reasons for nurse leaders to be engaged with antimicrobial stewardship. The objectives of the Infection Control and Prevention webinar series include describing infection control techniques that reduce the risk and spread of healthcare-associated infections, or HAIs, identifying unsafe practices that place patients at risk for HAIs, describing best practices for infection control and prevention in daily practice in healthcare settings, and applying standards, guidelines, best practices, and established processes related to safe and effective medication use. In this specific webinar, we will describe key reasons for nurse leaders to be engaged with antimicrobial stewardship, describe the problem of antibiotic resistance and embrace an expanded role in hospital antibiotic stewardship programs and activities. We'll provide education and increase adherence to clinical practice guidelines in the clinical education setting, and provide education that illustrates the importance of antibiotic stewardship and the roles of the faculty and students. So hello again, and welcome to today's webinar, Empowering Nurses to Protect Themselves and Their Patients, Nurses' Role in Antibiotic Stewardship. My name is Erica Tyndall, and I am a public health analyst and infection preventionist at CDC's Division of Healthcare Quality Promotion. The mission of CDC's Division of Healthcare Quality Promotion is to protect patients, protect healthcare personnel, and promote safety, quality, and value in both national and international healthcare delivery systems. This webinar is part of a series of infection control-related webinars that CDC will be hosting with the American Nurses Association and members of the Nursing Infection Control Education Network. Before we get started, there are a few housekeeping items to cover. We welcome your questions. Please submit any questions or comments you have via your chat window located on the lower left-hand side of the webinar screen anytime during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Hand button located on the top left-hand side of the screen if you need to chat with the meeting chairperson for assistance during the webinar. Also, the speaker slides from today's presentation will be provided to participants in a follow-up email. And as a reminder, today's webinar is being recorded. Please visit our Tune Into Safe Healthcare website in a few weeks for the recording. Before I pass it on to Dr. Sean Ross from the American Nurses Association, I would like to provide brief introductions for our three speakers. Barbara Gilbert is from the Academy of Medical Surgical Nurses. Barbara has been a registered nurse for over 34 years. She has served as the infection control nurse at AAA Army Medical Center in Hawaii since August 2009 and is certified in infection control. She supports a variety of inpatient units, clinics, and patient-centered medical homes. Barbara is involved in a number of infection prevention and control activities and HAI surveillance. Chris Shakula is from the National Association of Clinical Nurse Specialists. Chris received her master's degree from Purdue University and a bachelor's degree in nursing from Indiana University Northwest. She is employed by Franciscan Health Crown Point as an infection preventionist. She is board certified in infection and prevention and control and as a clinical nurse specialist. Chris has 25 years of nursing experience and is a member of several professional organizations including Sigma Theta Tau International, the National Association of Clinical Nurse Specialists, and the Association for Professionals in Infection Control and Epidemiology. Tricia Mims is from the National Student Nurses Association. Tricia previously served as a health center director at Johnson City Community Health Centers in Johnson City, Tennessee, where she also assisted in the development of community alliances and operational policies. She is a veteran of the United States Navy, where she served over 9 years on active duty and practiced in medical surgery, the operating room, and community health. Tricia earned a BA in biology from Texas A&M University and BS in nursing from Texas Tech University Health Sciences Center. She went on to earn both an MBA in healthcare management and an MS in nursing from University of Phoenix in Arizona. Now I'm going to pass it on to Dr. Sean Ross.
Thank you, Erica. My name is Dr. Sean Ross, and I am the Director of Nursing Practice and Work Environment at the ANA. Both the CDC and the Joint Commission specifically highlight the need to engage nurses as part of the multidisciplinary antibiotic stewardship effort. Despite these and other recommendations, efforts to engage nurses in antibiotic stewardship have been limited. In response to the critical need to expand antibiotic stewardship and in recognition of the central role that nurses play in patient care and quality improvement, CDC, along with the grant from the CDC Foundation, partnered with ANA to bring together a group of registered nurses to explore the nurse's role in acute care hospital antibiotic stewardship programs and to identify practical and feasible areas for nurse engagement. Staff at CDC and ANA selected approximately 30 healthcare professionals to serve on an expert advisory committee. Members were chosen to represent a diversity of geographic locations and expertise in acute care hospital settings. The work group held a series of virtual meetings, culminating in a one-day live seminar in July 2016. Conference attendees outlined the following key priorities. 1, publish a joint position statement. 2, identify and incorporate national nursing standards and metrics. 3, identify educational gaps. And 4, develop resources for nurses to seamlessly engage in hospital antibiotic stewardship programs. The ANA and CDC work group also worked with the ANCC Magnet Recognition Program to endorse 2 clinical indicators specifically as related to antibiotic stewardship. As a result, MRSA and C. difficile will be added as optional unit or clinic-level nursing-sensitive clinical indicators beginning with the 2019 Magnet Application Manual. In the summer of 2017, the ANA and CDC jointly published the white paper to inform registered nurses in the United States about the problem of antibiotic resistance and facilitate their embracing an expanded and clearly recognized role in hospital antibiotic stewardship programs and activities. The white paper discussed a few things. It reviews antibiotic stewardship programs and the current state of antibiotic resistance, provides a summary of the work group's discussions on current barriers to full nurse participation in antibiotic stewardship programs, gaps in nurses' knowledge and education about antibiotic stewardship, and the use of antibiotics in the 21st century. It also explores opportunities for nurses to add their expertise to our nation's ongoing stewardship efforts and offers recommendations for future nursing education. While this white paper is neither a formal nor a complete roadmap, it does succinctly outline ANA and CDC's ongoing efforts to place the nation's 3.6 million nurses in central roles in antibiotic stewardship efforts. The ANA CDC white paper can be found on the ANA website homepage under Hot Topics in the bottom left corner. So today's webinar is the 4th webinar within the NICE Network series, Empowering Nurses to Protect Themselves and Their Patients, the nurse's role in antibiotic stewardship. Today's webinar will use the joint ANA and CDC white paper to discuss the roles of nurses, nurse leaders, students, and faculty in antimicrobial stewardship. At this time, I will turn it over to Barbara Gilbert, representing the Academy of Medical Surgical Nurses.
Good morning. My name is Barbara Gilbert, and I'm an infection control nurse. This morning I'll be talking about the current state of antimicrobial resistance, antimicrobial stewardship and antibiotic use, and the nurse's role in antimicrobial stewardship. Starting with antimicrobial resistance today, where are we now? First, let's define the terms antimicrobial and antibiotic. Antimicrobials destroy disease-causing microbes and include antibiotics, antivirals, antifungals, and antiparasitics. Antibiotics target bacteria. In this document, Vital Signs, Improving Antibiotic Use Among Hospitalized Patients, published March 7, 2014, looking at patients discharged from 323 hospitals in 2010, the authors found that 55.7 received antibiotics during their hospitalization, and antibiotic prescribing could potentially be improved in 37.2%. An opportunity to improve use and patient safety by reducing incorrect antibiotic prescribing. Several other studies have documented the percent of inappropriate antibiotics as closer to 30. Antibiotics are not without risks, to include adverse drug reactions, infection with Clostridium difficile, also known as C. diff, which manifests as diarrhea and can cause pseudomembranous colitis, sepsis, and death, and other infections with antibiotic-resistant bacteria. We also know that new antibiotics aren't being developed as they have been in the past. Alexander Fleming discovered penicillin in 1928. It was used for wound infections in Allied troops during World War II before becoming available to the civilian population in 1945. When Fleming received the Nobel Prize in 1945 for his discovery, in his acceptance speech, he warned of bacteria becoming resistant to penicillin. Fleming said, "The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with a penicillin-resistant organism. I hope this evil can be averted." Fleming was a man ahead of his time. Using antibiotics creates resistance. How does this happen? As you can see in this graphic from the CDC, there are lots of germs. Some of them are drug resistant. Antibiotics kill the illness-causing bacteria and some of the good bacteria that protects the body from infection. Some bacteria are not killed, and their growth is not stopped. To make matters worse, some bacteria share their drug resistance with other bacteria. In other words, resistant bacteria survive, continue to multiply, and potentially cause more harm and spread to others. What is the effect of this antibiotic resistance? As you can see in this graphic from the CDC, resistant infections make a lot of people sick, and they make some people really sick. People with resistant infections tend to take longer to get better, and some of them die. Also, providers have to recommend second or third line drugs. Those drugs might be less effective, more toxic, and more expensive. For many nurses, Clostridium difficile, or C. diff, is the side effect we are most familiar with. To review, C. diff is a spore-forming, gram-positive anaerobic bacillus that produces two exotoxins, toxin A and toxin B. On the basis of data from U.S. death certificates, C. diff infection was the leading cause of gastroenteritis-associated death in 2007 and was estimated to have caused 14,000 deaths. Again, that was in 2007. This article, published in the New England Journal of Medicine in 2015, estimated that C. diff caused approximately 453,000 infections and was associated with approximately 29,000 deaths in the United States in 2011. The authors came to this conclusion on the basis of data from active population and laboratory-based surveillance across diverse geographic locations in the United States. This estimate of C. diff infection is obviously higher than the previous estimates. And what about the shrinking pipeline of new antibiotics? Well, there's been a relative explosion of antibiotic-resistant infections. There has been an equally alarming decline in the research and development of new antibiotics. Why is that? There are multiple factors. First, drug development costs lots of money. Antibiotics are, generally speaking, short-course therapies with the goal of curing their target disease. Medications for chronic diseases can go on and on and on. There's a greater return on investment for their development. Second, the push to, very appropriately, limit the use of broad-spectrum antimicrobials negatively impacts their sales. And third, the lack of available guidance documents from the FDA regarding which studies and evidence the agency considers acceptable to demonstrate safety and efficacy of new anti-infective drugs. Antimicrobial stewardship is about improving prescribing and use. Of course, these drugs are a limited and exhaustible resource. The more they're used today, the less likely they'll work in the future. Healthcare professionals are adopting principles of responsible antimicrobial and antibiotic use, often called antimicrobial stewardship. Stewardship is a commitment to use antimicrobials only when necessary to treat and in some cases prevent disease, to choose the right antimicrobials, and to administer them in the right way in every case. A formalized stewardship program will decrease unnecessary exposure to antimicrobials, improve infection cure rates, reduce adverse drug reactions, slow antimicrobial resistance, and result in cost savings. In 2014, the CDC recommended that all acute care hospitals implement antibiotic stewardship programs and develop the core elements of hospital antibiotic stewardship programs. It outlines 7 components that have been linked with success. Number 1, leadership commitment, providing the needed human, financial, and IT resources. 2, accountability, appointing a single leader responsible for program outcomes. 3, drug expertise, appointing a single pharmacist leader responsible for working to improve antibiotic use. 4, action, implementing at least one recommended action. 5, tracking, monitoring antibiotic prescribing and resistance patterns. 6, reporting, regular reporting on use and resistance to providers, nurses, and other relevant staff. And 7, education, educating clinicians about resistance and optimal prescribing. In mid-2016, the Joint Commission announced a new medication management standard for hospitals, critical access hospitals, and nursing care centers. Standard MM.09.01.01, the hospital has an antimicrobial stewardship program based on current scientific literature, became effective January 1st, 2017. This standard's 8 elements of performance are based on the CDC's core elements of hospital antimicrobial stewardship programs and, in 2017, were as follows. 1, leaders establish antimicrobial stewardship as an organizational priority. 2, the hospital educates staff and licensed independent practitioners involved in antimicrobial ordering, dispensing, administration, and monitoring about antimicrobial resistance and antimicrobial stewardship practices. 3, the hospital educates patients and their families as needed regarding appropriate use of antimicrobial medications. 4, the hospital has an antimicrobial stewardship multidisciplinary team that includes the following members when available in the setting: infectious disease physician, infection preventionist, pharmacist, practitioner. 5, the hospital's antimicrobial stewardship program includes the following core elements: leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. 6, the hospital's antimicrobial stewardship program uses organization-approved multidisciplinary protocols, such as policies and procedures. 7, the hospital collects, analyzes, and reports data on its antimicrobial stewardship program. And 8, the hospital takes action on improvement opportunities identified in its antimicrobial stewardship program. What can nurses do? First, medication administration is important. As an example, I remember when a provider ordered an IV medication, for a patient with C. diff. Medication for C. diff works better if it goes through the gut. However, we nurses need to think beyond medication administration. Second, obtain appropriate cultures using proper techniques before starting antibiotics. For example, for blood cultures, disinfect the bottle tops with 70% isopropyl alcohol. Clean the puncture site with alcohol, followed by chlorhexidine, gluconate, or CHG, and allow to dry. Then collect the appropriate volume of blood. For adults, that's 10 to 20 cc's for each blood culture set. For sputum cultures, have the patient rinse with water to remove excess oral flora, then instruct the patient to cough deeply and collect the specimen in a sterile container. Third, review microbiology results and sensitivities and ordered antibiotics. Is the bacteria sensitive to the prescribed antibiotic? Fourth, be aware of the indication and intended duration of antibiotics. I love it when the provider specifies the indication when ordering an antibiotic, or any medication for that matter. Fifth, notify the physician and pharmacist of any adverse effects and if the patient refuses an antibiotic. Sixth, verify the antibiotic schedule when a patient transfers. Make sure that is part of your patient handoff. 7, take a detailed allergy history. The label penicillin allergy is associated with increased selection of antibiotic-resistant organisms, longer hospital stay, and increased costs. 8, be smart about sepsis. Sepsis is the body's extreme response to an infection. It's life-threatening, and without timely treatment, can rapidly cause tissue damage, organ failure, and death. It is a medical emergency, and time matters. Ensure antibiotics are started promptly and reviewed once culture results are available. Talk to the team about antimicrobial usage, including de-escalation and changing from IV antibiotics to oral antibiotics. No sepsis signs. While there is no single symptom of sepsis, symptoms can include a combination of any of the following: confusion or disorientation, shortness of breath, high heart rate, fever or shivering or feeling very cold, extreme pain or discomfort, and clammy or sweaty skin. Identify and treat these patients early. 9, prevent infections from the get-go by following infection control practices like hand hygiene and removal of invasive devices such as central lines, even peripheral IVs, and urinary catheters as soon as possible when no longer needed. When I'm making rounds and talking to patients and family members, I tell them that any invasive device is an opportunity for germs to jump in. The sooner they can get rid of it, the better. 10, encourage patients to get recommended vaccines. 11, be at the table. That is the Antimicrobial Stewardship Committee. Invite yourself if you need to. And 12, educate your patients and families about preventing infections, keeping scrapes and wounds clean, managing chronic conditions, recognizing early signs of worsening infection and sepsis, and getting immediate care if those signs are present. When antibiotics are not necessary, especially if they demand them, to complete antibiotics if prescribed, and to not share antibiotics or take them if they're not prescribed for them. There are lots of great resources available for patient, family member, and staff education, and there is no need to recreate the wheel. I've included 3 graphics that are available from APIC, the Association for Professionals in Infection Control and Epidemiology, and the CDC. All right, time for a reality check. Consider these questions I know you're not able to respond online, but it's a good opportunity for self-assessment. Number 1, antibiotics are drugs used to treat bacterial infections. True or false? That, of course, is true. Number 2, antibiotics will work on viruses like the common cold, the flu, and bronchitis. True or false? That is false. 3, I can stop taking my antibiotics as soon as I start feeling better. True or false? Of course, that's false. Number 4, I can take antibiotics prescribed for someone else. True or false? That is also false. Number 5, using antibiotics the wrong way can cause bacteria to grow into superbugs, that is, bacteria resistant to antibiotics. True or false? That is true. Number 6, how many people in the United States annually get an infection that cannot be treated by antibiotics? At least 1 million or at least 2 million? The answer is at least 2 million. I want you to prevent the spread of antimicrobial resistant infections. If you have ideas, actions that nurses can take that we've not discussed, I'd love to hear them during our question and answer time. And now I'm happy to introduce Chris Shakula, representing the National Association of Clinical Nurse Specialists. Chris?
Thank you, Barbara. I will be discussing why nurse leaders need to be engaged in antimicrobial stewardship. So why do nurse leaders need to be engaged in antimicrobial stewardship? Leaders are responsible for making sure regulations are met, patients are safe, and that nurses are part of institutional programs and not just engaged at the bedside. When we first started our antimicrobial stewardship program, I was asking myself the same question of why I needed to be involved. In my current role as an infection preventionist, I do not prescribe medications. So why did I need to be involved, and did I really need one more item added to my list of things to do? But as I learned more about antimicrobial stewardship, I realized how important it was for me and for nurse leaders to be engaged. I also learned during my preparation for this presentation how much nurses are already doing at the bedside related to antimicrobial stewardship, but may not know it and may not be involved beyond their work at the bedside. Leaders are also in a prime role to influence multiple modalities. From a CNS perspective, CNSs function in multiple spheres, or what we call spheres of influence, as depicted in the diagram. The 3 spheres are client, nurse, and systems. For antimicrobial stewardship, this allows us to show how nurses at the bedside can affect antimicrobial stewardship and also let management know why nurses need to be involved beyond the bedside. Antimicrobial stewardship is also a patient safety issue. Antibiotics are a main risk factor for C. diff and drug-resistant organisms such as MRSA, VRE, CRE, and many others. Most treatments or actions in healthcare only affect one patient, but antibiotics affect everyone. The following quote is from an article in Clinical Infectious Disease titled, "The Critical Role of the Staff Nurse in Antimicrobial Stewardship, Unrecognized but Already There," by Owens. Antimicrobial stewardship acknowledges the unique repercussions of antimicrobial agents as communal medications, affecting more than just the individual patient and having an impact on future infections beyond the currently treated illness. One thing about resistant organisms is that the patient taking the antibiotic may not be the only one affected by it. Resistant organisms can be spread from person to person by poor hand hygiene and inanimate objects that are not being cleaned and disinfected appropriately. Antimicrobial stewardship also affects nursing workflow. IV to PO medications. There's a difference in the time nurses spend giving PO medications versus IV medications. Patients on antibiotics that are not de-escalated or changed in a timely fashion may have longer hospital stays. Patients with contaminated specimens may have longer hospital stays and be exposed to antibiotics that aren't needed. Proper specimen collection is a topic that I recently covered during one of our nursing education days. Several nurses didn't realize how much is affected by culture results. Those results may affect whether or not a patient receives an antibiotic, They may affect the length of stay of a patient and if additional testing requirements are needed. Nursing involvement in antimicrobial stewardship is also being required by several regulatory bodies. The Joint Commission, which has already been mentioned, is one agency. Another is the Healthcare Facilities Accreditation Program, or HFAP, which our facility uses. Magnet recognition is adding measures such as C. diff and MRSA, which are related to antibiotic use as well. Antimicrobial stewardship is also part of pay-for-performance or value-based purchasing. The Centers for Medicare and Medicaid Services, or CMS, has a proposal to make antimicrobial stewardship a condition of participation. Some insurance companies have already added it as an indicator which they base payment off of. Anthem is one of the major insurance companies in the Midwest where I am located, and it is already an indicator. So in summary, nurses are already a part of antimicrobial stewardship. Leaders need to ensure that they are engaged in antimicrobial stewardship programs and understand why their participation is vital. Thank you. It has been a pleasure to participate in this presentation. Now Tricia Mims from the National Student Nurses Association is going to speak.
Good afternoon. I'm excited to join this great panel. I'm going to summarize my colleagues' presentations into an outline for the clinical teaching environment. We all have highlighted that improving the use of antibiotics is a national priority, that is important to patient safety, and has become a public health issue. As my colleagues have noted, the key to prevention is not just one provider. The NICE network, along with the reference white paper, highlight that it is a team approach. We know that teaching the correct clinical practices and empowering the nurse starts in a clinical education setting. The objectives for you to take away today encompass understanding the goals of antibiotic stewardship, an overall review of antimicrobial resistance and stewardship, and the application in the clinical teaching environment. As well as we'll identify the 4 actions and multiple educational gaps with the conclusion of the role of the faculty and the students. My goal is to assist you in understanding how you play a role in preserving the effectiveness of antibiotics. As a student and faculty, your role is vital in connecting education to the clinical setting. First, we must understand the goals of antibiotic stewardship. As my colleagues have noted, antibiotics are among the most commonly prescribed drugs used in human medicine and can be life-saving drugs. However, up to 50% of the time, antibiotics are not optimally prescribed, often done so when not needed, where there is incorrect dosing or duration. Regardless of the setting, the primary goals are the same, and that is to optimize the therapy and the outcome while preventing resistance. Student nurses and faculty can assist with antibiotic stewardship through patient education, being a patient advocate, and also being a voice for the need of this widespread behavioral change. The faculty member is key as they provide education to the students on appropriate use, timely and appropriate antibiotic selection that is evidence-based, dose optimization and de-escalation, and the importance of understanding the impact of duration. All of this empowers the clinical team to provide the best standard care and be a change that can minimize the spread of resistance. 4 core actions to fighting this resistance. Currently, providers are having to recommend second or third choice drugs for treatment when the bacteria that causes infections are resistant to the drug of choice, and this drug doesn't work. But the alternative drug might be less effective, more toxic, and more expensive. Today, we will emphasize the actions that are needed for leadership by nursing programs. For the educational setting, it is important for students and faculty to understand the 4 core actions to fight resistance and their role as patient advocates that provides care that is evidence-based. 1, preventing infections and spread of resistance. Patient education is key to this action. We know that avoiding infections in the first place reduces the amount of antibiotics that have to be used and reduces the likelihood of resistance. In clinical teaching settings, we need to emphasize the importance of teaching the patient and the family about prevention. Easy teaching topics for students include discussing immunizations, safe food preparation, hand washing, and using antibiotics as directed. Action 2, tracking antibiotic-resistant infections. It is key to teach the students and others on the interdisciplinary team the importance of reporting to local health departments, CDCs, or other regulatory bodies. The CDC gathers data on antibiotic-resistant infections, cause of infections, and the risk factors. Action 3, improving antibiotic prescribing. A key in the clinical education setting is the education that is given to the student about the importance of cultures, the techniques involved in collecting the specimen, when to collect, and how to read the report. Understanding the results can help the student get a voice on the clinical team. We want to make sure the antibiotics are given only when needed, that the right antibiotic is prescribed and administered correctly. The instructions given in the clinical setting teaches the students to ask these questions as they prepare for antibiotic administrations, which can prompt often the discussion of antibiotic treatment, indication, and duration. Action 4, developing new drugs and diagnostic testing. There is always new research and tests, so it is vital for both faculty and students to continue to stay up to date through articles and webinars, like today. We encourage both the faculty and your students to subscribe to the CDC, the ANA, and APEC, and other resources that can help you identify the new antibiotics and tests available. We want you to be able to continue to teach and provide evidence-based care. Closing the gap in educational settings. This issue at hand is a gap. Nurses have recognized that there's an educational gap regarding antibiotic use and microbiology. This gap is mentioned in the reference paper. You, as faculty, can close that gap early by providing evidence-based education to the student nurses so they can provide great nursing care, which is key to antibiotic stewardship. I'm going to highlight these gaps that you see. We know that we may not fully grasp the concept of antimicrobial stewardship. We may not feel secure in our knowledge of microbiology and antibiotic use. We may not know our role or the impact that we can have. We do know that nursing and the interdisciplinary team can overlap. So if we can teach those overlapping areas while in the educational setting, we can be key players in assisting with stewardship. A few suggested points for educators is to emphasize to the students the importance of microbiology and pharmacology. Students need to know how to obtain cultures, correct time and technique. Microbiology should be included in every class, not just in the microbiology course. Understanding the labs and identification of specific bacteria and sepsis. Do they understand infections versus colonization? It is important to recognize contamination of a specimen as well. It's also important to have a voice if that happens. Being a player in the discussion of therapy and the evaluation of the patient, and being an advocate for the change for duration and route is about filling these gaps. We need to understand the drugs that we are giving, the course of action, and the impact, which goes down to the basics of the pharmacology of the drug. We need to emphasize and train on detailed allergy histories, physical assessments, and past antibiotic and medication use. We always need to be aware of new evidence-based practices and protocols. In conclusion, we want you to bridge, engage, and commit. Bridge the gap early in the educational setting. Knowledge is power, and our practice needs to be evidence-based. As faculty, students, and practitioners, we need to be refreshing our knowledge through webinars, articles, and joining our pre-professional and professional organizations that provide numerous resources. Get connected to the CDC. Engage. Engage and be assertive in the discussion with the healthcare team. As my colleagues have highlighted, nursing involvement is required by the Joint Commission and other accredited bodies, and we can have an impact from the bedside to leadership, from giving outstanding patient education to giving assistance with policy and protocol changes, and most importantly, being an active voice in our roles as educators, practitioners, research, and leadership. Most important is to commit. Commit to advocacy. This takes the commitment by all of us, from the educational setting and beyond. We leave you with this challenge. In your role as a nurse, how can you bridge, engage, and commit? I thank you for your time today, and I will now pass the presentation back to Dr. Rouse.
Thank you so much, Tricia. We heard a lot of great information today about nurses' role in antibiotic stewardship. In summary, the role of the nurse in antimicrobial stewardship is to, 1, perform appropriate assessment and isolation, 2, ascertain accurate antibiotic allergy history. 3, obtain early and appropriate cultures. 4, perform timely antibiotic initiation and administration. And 5, educate patients and their family members. Nurse leaders' primary role is to ensure staff nurses are engaged in antimicrobial stewardship. So I think at this point we go to the questions.
Well, this is Erica from the CDC. I just wanted to mention that today's presenters have emphasized the critical role nurses play in stopping the spread of antibiotic resistance. And as they reminded us, new types of resistance are constantly developing, making some germs untreatable. If we do not identify and respond to unusual resistance rapidly, untreatable infections will become more common. Nurses and the healthcare team are often the first responders, so here's what you can do to help slow the spread of resistant organisms. Assume unusual resistance will arrive in your facility. Ask patients about recent travel and healthcare to identify at-risk patients. If unusual resistance is found, inform patients and their family and communicate the presence of resistant organisms to accepting facilities when patients are transferred. Place patients with unusual resistance on contact precautions, assess and improve infection control, and work with the health department to screen other patients for unusual resistance. And lastly, continue infection control assessments and screenings until transmission is controlled. You'll be hearing more about this important work when CDC releases the April 2018 Vital Signs on slowing the spread of antibiotic resistance. And if you're interested in learning more about antibiotic use, please email us at antibioticsuse@cdc.gov to join our antibiotic use mailing list. Again, thank you to all the speakers for your time and expertise today. As a reminder, please submit your questions via the chat window located on the lower left-hand side of your webinar screen. And now I'll turn it back over to Dr. Ross to facilitate the Q&A session.
Thank you, Erica. The first question is going to be for AMSN. What are your thoughts on the use of molecular diagnostics in the identification of infectious disease and infectious disease and antibiotic-resistant genes in antimicrobial stewardship programs? I'm not sure if you can answer that or not.
Well, my experience, this is Barbara from Tripler and the AMSN. We have a little bit of experience with this in my work environment as we tried to figure out if there was some in-house transmission going on. So we had sent some specimens, of course, in coordination with our infectious disease physician, and our microbiology colleagues had sent some specimens off to another facility for additional testing to see if for instance, ESBLs were linked or if ERE had some connection to see if we were somehow spreading these among patients. So I think this is a great tool for us to know whether or not we were contributing, we healthcare professionals, the healthcare team were contributing to this happening among patients. Tell me if I've answered the question.
I think.
Okay. In some cases, we had, we were part of that. In other cases, it was wonderful to know that we had not contributed. The conclusion, based on the input from our colleagues, was that the sources were coming from outside our hospital. That the molecular diagnostics showed they were not closely related.
Thank you, Barbara. This next question is for NACNS. Do you ever use natural products like grapefruit seed extract?
This is Chris at our facility. No, we do not.
Another question is, what is the best way to collect a urine culture from a patient with an indwelling urinary catheter?
This is Chris. You should be using the sample port that is closest to where the Foley connects to the drainage tubing, and you should be swabbing off that sample port before collecting your specimen. You never want to be collecting a specimen directly from the collection bag itself.
Thank you, Chris. This question is concerning a surgeon who orders ANSEF and vancomycin for pre-op prophylaxis in total joint patients when the patient is MRSA negative. He cites evidence supporting this, and the infection preventionalist has spoken to him but refuses to change his practice. So any thoughts on using ANSEF and vancomycin in the pre-op phase for patients?
This is Barbara from AMSN. We have been working with a multidisciplinary team based on our NISCIP data to improve our SSI rates. They're not what we would like them to be or what they need them to be. And as part of that work outside the Antimicrobial Stewardship Committee, we've had pharmacy come and make sure we are current with the recommendations, preoperatively, intraoperatively, both in terms of the what, the how often, the weight-based dosing. And so if there is a forum such as that at your facility, that would be great. If not, I would refer that question to the Antimicrobial Stewardship Committee.
Thank you, Barbara. I would agree with you that that's probably a better question for that committee. The last question is, what antibiotics should a facility be tracking for their antibiotic stewardship program?
This is Barbara from AMSN. I don't know that there is a one-size-fits-all answer for that question. Our microbiology team produces an antibiogram at least every 6 months, kind of rolls and updates about epidemiological significant organisms and resistance patterns, and it's separate for outpatient as well as for inpatient. So it really depends on what is happening in your area. And then in the state of Hawaii, there is a statewide antibiogram. So again, I think you're going to have to work in conjunction with your pharmacy, your microbiology to produce that for your very specific location, as well as an expanded geographical location. Again, we have one for the entire state.
Thank you, Barbara. I'm turning this over to Erica.
Okay, well, thank you for submitting your questions today via the chat box. This is all the time that we have today for answering your inquiries. Please stay tuned for a follow-up email that will include the slides from today's webinar. And lastly, to receive continuing education, you must complete the continuing education post-test and evaluation. Please follow the detailed instructions that will appear on the post-meeting web page right after you close out the webinar. You must complete and pass the post-test activity at 66% to receive continuing education. For those on the phone who currently aren't logged into ReadyTalk online, to obtain continuing education, please go to www.cdc.gov/TCE online. The access code for this webinar is ANA CDC 4. Again, that's ANA CDC and the number 4. A follow-up email will also be sent after the webinar with detailed instructions about completing the continuing education, post-test, and evaluation. We will also send out another email when the recording is available on the CDC Tune In to Safe Healthcare website. So please check that website for this webinar recording and PowerPoint slides. With that, I'd like to thank our speakers as well as you all for taking the time to join us today and for your commitment to keeping your patients safe. Thank you so much.